Hello and welcome to Health Matters on Channels Television. Thanks for joining us on the program. I am Mary Alale Yusuf. According to the Johns Hopkins University website, globally on April 11th by 8:22 GMT, there were almost 1.7 million confirmed cases of COVID-19 and over 100,000 deaths in 185 countries. More than 370,000 of the confirmed cases have recovered. The United States of America is now the epicenter of the disease, with more than 500,000 affected people, representing about 29% of global cases, just from the US. For the same time period, Nigeria had a total of 305 confirmed cases, 58 recoveries, and 7 deaths. Lagos is the epicenter of Nigeria's outbreak with 163 cases, which represents more than 53% of the total case burden in the country. My guest is the president of the Healthcare Providers Association of Nigeria. He's also a public health consultant, Dr. Adeyeye Arigbabuwo. You are welcome to the show, sir.
Good afternoon.
I've been hearing, I'm so curious about this, and I want it out there, that there are some other early signs of COVID-19 which one can use to actually raise the suspicion that somebody can be experiencing or somebody can be positive with the disease, and that is the smell, sensation, and taste of the person. Can you tell us more about that?
Well, there are protocols or various stages of evolution of suspicion or indices of suspicion in this situation. You've heard about cough, you've heard about difficulty with breathing,
yes.
You've heard about sneezing, fever, and all of that. Yes, other constitutional symptoms or what you call signs like you have just mentioned now. It is not compulsory. This will be present in all of the patients,
yes.
For example. So, as it were, when you are trying to elicit the chances of somebody suffering from this, yes, if you get it, loss of taste or loss of smell, it is not pathognomonic. What we mean by that is that it is not a condition that must be attached to your suspicion.
Yeah, but so then if it does happen,
if it's present,
could raise the
present
suspicion.
could just be an additional,
an additional help
yes,
to diagnose,
to start throwing your suspicion to the case. And again, there are days in the incubation period or exhibition that you will be seeing some of these things. Not that all of them are things you are going to box at just one time of seeing the patient.
Okay.
Yeah.
Okay. So just some additional help there. Okay, if we maintain this social distancing, hand hygiene, respiratory hygiene, all the things we've been told to do, how long do you think we're going to sit through and endure this? How long is it going to last?
Yes. The sermon I've always preached is that the virus does not move. We are the ones moving. So if we limit our movement or we don't move, and the virus is not transmitted from one point to the other, I can tell you the worst case scenario, for example, for a parasite to do on the host, and God forbid it, the worst case scenario is to kill the host.
Okay.
Which means that particular virus will not go beyond that host, will end the journey there.
Okay.
And if we look at the fatality, I mean, it's okay, this is mortality rate, this is morbidity rate, this is how people die of it, that kind of a thing. You can see it's very low percentage.
That's
we invariably die of it. So it means that this virus can be halted if we limit our movement.
There's something else that is, baffling me. Why are so many more men getting it than women? Is there a reason?
Well, because the virus is novel. I can tell you it's a dynamic situation. We're still studying the pattern and the behavior of this virus. We do know that, yes, all of us have agreed that the immunity of the patient is important, or of the victim is important. So the gender bias or the gender sensitivity or the gender option, for example, will still be a case study for the future. It's too early.
It's too
early. As far as I'm concerned.
Okay, but there's something I want to ask you. Is it too early? If you look at the United States of America, for example, look at those cases. More than 500,000 cases now, and almost 33% or almost a third of, all the confirmed cases. What are they doing wrong? What can we learn from them?
Yes, thank you. The same question will also come. What is Italy doing wrong? What is Spain doing wrong?
I think Italy has started to decline, haven't they?
Yeah, well, even then, what did they do wrong initially? And what has Spain done wrong? And again, I will also want to let you have this question. What is Nigeria doing wrong now that the state is rising? I've never seen a day now without us catching new cases. So what have we done wrong and what are we doing wrong? So like I mentioned, that this virus is novel. All eyes and all hands must be wide open like this, and we begin to study and begin to compare notes. We compare notes from countries that have mortality that's been high, countries that have relatively gotten the cases but no death yet, the ones that have had their death toll, and the ones that are trying to flatten up the curve, for example. We all should be comparing notes, and that is the truth.
We should.
And like I keep telling you, we got this outbreak in December. Like in Nigeria, you and I, were we sincerely going to be able to say this was exactly when this COVID-19 entered Nigeria? When did we start testing? So there are plenty of questions. And so I cannot fault America that there were probably certain things they were not doing right. We should even with physicians, a time might come, as things are getting unfolded now, a time might come we might also even ask ourselves, our management protocol so far, have we all been applying the right thing? We have the NCDC, yes, right? For a novel thing, there will be evolution and revelation, which will be coming up with time. And we keep on adjusting our model or protocol, for example, as new things emerge. Okay? You've been reading, some physicians have been talking, even from the USA, from New York, for example. I had a friend who just chatted with me and said, look, these ventilators we are using, are we really on board? Are we really not doing probably more damage than what it is? That might be his personal opinion, seeing what is lying before him. At a time that all of us will agree, and science and research will prove whether it is more deleterious using it or not. But the truth is that we need the ventilator. But behind the ventilator are the metabolic changes and the pathophysiology of the case itself. What are the issues involved in the case? Are there going to be other multidisciplinary specialists that will be involved? Like a hematologist? Like, oh, how is this hemoglobin behaving? Like, how are the competitive receptors? These are all academic issues.
Okay, so what can we say now could be the adverse effects of coming down with COVID-19? That's after the person has recovered,
yes,
and is okay.
Yeah.
Are there some adverse effects that the person has to deal with later on in life?
Thank you. Borrowing from Ebola saga in 2014, for example, yes, some countries we exchanged notes, and we learned of some people having post-Ebola neurological problems, maybe nerve system problem and all those things. In this case scenario that we are dealing with now, the truth is that somebody tested positive today, and okay, next week he said, oh, I'm now negative. Oh, maybe some other couple of weeks, other words, he said, oh, I am now positive.
So how do you explain that? Thank
you. So the dynamic nature, the virulent nature, and possibly the mutation pattern, and a lot of issues that surround this virus need time, research, data, statistics, case comparison, case study, and in fact empirical evolutions as we are dealing with the cases. let us know. And again, it is damn too early to begin to also talk of post-COVID-19 patient syndrome.
Okay.
That is, oh, you are a recovery, you have recovered. What are the consequences? What are the things you suffer from?
How long do we have to wait before we begin to document those things?
Yes. First thing we should first of all know is that the first question is, patients we have declared okay, we need to monitor them.
Okay.
We don't just say okay, throw them back to the society and nobody's monitoring.
Okay, should they monitor them at home, or do you think they should retain them?
In my own opinion, there should be a consulting follow-up period. A period appointment we give to such patients or people who have discharged to be seen us on outpatient basis of monitoring and evaluation, including our Center for Disease Control monitoring and even epidemiological monitoring. We have to monitor them. We need their statistics. We need their address and locations. We need their contact. We need to monitor them for a period of time so that we can make our documents.
Okay. Now, I heard some very disturbing news that some people who have recovered from COVID-19, they've tested negative on 2 occasions, 2 different times. They've been thrown out of their communities. People rejected them. They said, we don't want you back here. What do you have to say about that?
Yes. The first thing in my mind, first of all, is that depending on the country, and every country, for example, should also obey and maintain the protocol of the Center for Disease Control. For example, some people use rapid diagnostic test kit, for example, to diagnose their case. I think Nigeria is using something WHO and UNESCO.
We've been assured that
yes,
we're using
so that with the polymerase and biological
test.
testing, which is far more reliable than this spot test, for example. So if we say we've done the test 2 times and the patient or the sufferer or the victim is declared okay, the next of event you see where somebody is being sent into exile, let me put it that way, away from his people, is only a demonstration of socio-cultural illiteracy syndrome. And whatever you think of it, you want to make the person look abominable for a case that no one should take guilt of. It is not a social misdemeanor. It is not attached to sexual malpractice or anything that a community or a society, especially in the African context, will say, no, look, this is an abomination to our society, so we can move.
Let me pause you there, Doctor.
Reasonable.
When we come back, we'll continue talking about this.
Thank you.
Please stay with us and meet us on the other side of the break. Welcome back. This is Health Matters and we're discussing COVID-19. If you have a question, you can call 0805-468-3514. That's 0805-468-3514. You can also tweet at CTV_Mary A for your questions. Before we go back to that issue of discrimination, let me quickly ask this. I'm not sure it's in your purview, but I do want to hear what your thoughts are. Abdul Ghani is asking on Twitter, can the medical sponsor a bill to stop medical tourism to help us develop our healthcare system? I mean, in the light of what's going on now.
Thank you. Medical tourism on its own is a baby of necessity and inadequacy from a system. If you begin to look at a destination where you are going, it's because your own system is either not providing what you want,
or you feel it has failed you.
But I do want to believe that this is an eye-opener. And luckily enough, a couple of our doctor colleagues are now parliamentarians. They are in the House of Representatives or the Senate. As I talk to you now, the chairman, House of Representative Committee on Health, is Dr. Tanko Sonono, who happened to be the immediate past Secretary General of Nigeria Medical Association.
Okay, so that's
so
good
it's an advantage
for you.
It's an advantage that if we as health workers want to push our bill, we can push. And there's nothing bad in pushing, because even whether we like it or not, with this experience now, where our E2 destination is even rejecting us, unquote, that says stay here. If I give you a visa now and I give you Moyesta code and everything to go to UK or America, and I'm sure you're not going to go. You will not go. So it means stay at home, develop your own culture and your system. In 1948, Indian people try what they call the tri-story for India to become drug sufficient. Today, they are better off for it. So something will cause, the price is getting too big for us to pay anyway, but something will open our eyes to the fact that we don't have to cry out. The other time we were crying to some people to donate some ventilators to us, and it's like we were tongue lashed. And these ventilators were not given to us. And we quickly withdrew the Twitter and we said, we're sorry whoever begged for it. That kind of a thing. It means look inwards, look inside, develop your healthcare system.
Okay, so let's go back to the discrimination issue. What do you suggest we do for a lady, a man who is being rejected from their society? Can't we do something about it?
If you ask me, that particular citizen has a right to life, has a right to where he or she wants to live, and we are not in medieval age, so he can seek legal redress.
Let's quickly take this call from Raphael. Hello, Raphael.
Hello.
We've lost Raphael? All right, let's move on. Now, the testing capacity, they say, is increasing every day. What is the implication of this? Do you think we're going to see more cases because there are more tests, or that we are sort of seeing the true picture of what's happening now?
Thank you. If you ask me, if in the country we're doing about maybe 200 testing in a day,
to 300,
so that kind of a thing, to me, it's grossly inadequate, because every second matters in this situation. It means we can look around and have accredited centers, including some accredited private centers that can be properly monitored, and increase their capacity, empower them to increase our testing velocity, frequency, and traffic, to the extent that we can catch as many more as possible before dissemination. Community contagiousness, community case of infectivity is much more dangerous than these foreign cases that we were saying were coming in, and imported, that kind of a thing.
Now,
if community contagiousness has increased, we have big work or big job at hand. It means we need to act quickly also. And how do we act? There's nothing to panic about. We only expand what we have now. And we should also, to me, in a country where 65 to 70% of the healthcare delivery is private sector driven, we should increase the capacity and open the net and make them the goalkeepers, who are mainly, as we see today, the private sector. Expand to them, accredit some of them, not all of them.
let's quickly take this phone call.
And could be at regional level.
Hello, Mohammed.
Hello. I'm calling from Meduguri, Mohammed. My name is.
You're welcome. What's your question?
My question is about the temperature resistable to the COVID-19. Hello?
Go ahead.
Some people do disseminate on social media that the virus does not tolerate temperatures that exceed 26 and 27. What is the veracity of their claim?
Okay. So Mohammed is asking, did you hear Mohammed's question?
No, I didn't.
That temperatures, that the virus does not tolerate temperatures that exceed 26 and 27 degrees centigrade. I don't know where he got that from. What's your take on that?
Well, as far as I'm concerned, scientifically, that virus is not a respecter of temperature for now. It's also neither a respecter of the weather of where your country is located. We say it's pandemic. It means whether temperate region, whether hot region, whether you're talking of humidity or whatever, this virus is present in there. And the virus is now distributed virtually in all countries of the world, except for a couple of exemptions, where we have not.
Let me quickly take Elvis's tweet. Elvis said, we were told, but I beg to differ, that the only treatment for COVID-19 is a lockdown. So I want you to educate us apart from the lockdown, what should we be doing? Should we even continue a lockdown?
Thank you. He called it treatment.
Yes.
I wouldn't maybe actually put it the way he actually wanted to look at it. It's not really treatment. It's a way to mitigate. It's a way to reduce. It's a way to quickly make sure we get on top of the matter. There have been suggestions. We've been treating now symptomatically based on what we see and supportive. We do know immunity has a role to play. Yeah, you've heard about this chloroquine issue, this hydroxychloroquine issue, and maybe most Stromax and all those things that are coming up. Yes, all this we are looking at them scientifically. For example, if you look at the textbook of medicine many years ago, the effect of chloroquine tried to create alkaline environment to prevent virus from attaching itself to the cells.
Is that where they got it from?
It's age long, and
but
it's now
there's
working.
this thing about social distancing. Is that still very important?
Social distancing is important in one or two ways. For example, somebody wants to cough or sneeze suddenly, might not be able to give you excuse because a reflex action. For example, it's a reflex. Yes. If I'm so close to you and I have the reflex of coughing, it might just have triggered up before I could just say, I'm sorry, or excuse me. I might have done it. So social distancing is good. Is something we believe will help us to reduce the chances of contacting the disease. And I also talk about physical distancing instead of say social distancing. Because using my handset, what we're doing now, this is physical distancing. But then with my handset and everything, I'm increasing even my social contact.
That's right.
Because of this disease. So
Distance
to say
socializing.
Yes, thank you. I'm ordinarily by using social media and everything. I'm even increasing social get together. But physically, I'm trying to distance myself. So that's the way we should understand what it is.
Thank you so much for coming, Doctor. I know that we can go on and on and on. We'll have you back, obviously, but that was really great. Thanks for coming. And thanks for being with us at home.
People should not forget this.
Social distance.
Should not forget this.
Don't forget your mask if you are coughing or sneezing or you're in a crowd. Don't forget social distancing, your hand sanitizer, washing hands with soap and running water, and stay safe. I am Mary Alale Yusuf.